talk will have two parts. The second part is what you see here in the title, Smoking and the Length of Working Life. This is a specific paper I will show you. The first part will introduce you more broadly to the topic and the work I've been doing on it. And when, no, this is not working. No, it is. When I talk about the length of working life, I want to answer the question, how many years do we work throughout our lives? And very simple question, how long do we work? But you can answer that potentially in different ways. If I would ask you, how long will you work today? You could say, well, I will work until 4 p.m. or something like that. Or you could say, I will work 8 hours. And if you look into the literature, when people talk about the length of working life, you find in a similar way different answers. Some people look at, for instance, retirement age, actual retirement age, planned or expected retirement age, things like that. But that's not what I'm doing. I'm looking at the duration of working life. And I do that mostly with an indicator called working life expectancy. That's our measure of the length of working life. And it's defined as the average lifetime spent in employment. So you can imagine, for us people here in this call, at some point in the future, all of us will have stopped working. And then we could ask everyone, how many years did you work throughout your life? And then some might say 45 years, others perhaps more or less. We take all these values, calculate the average, and then we would have the working life expectancy for the people in this call here. This abbreviation for working life expectancy, HWLE, I will use that throughout the slides, so it's good to remember that. Why one should perhaps study working life expectancy, why is it interesting? There's a couple of angles to it. What I'm mostly interested in is population aging. And I might partly be preaching to the choir here, but I will still give you the spiel. So in many high-income countries, populations are aging. You know that it's happening in the UK, as it is, for instance, in Germany, where I'm currently am. And this leads to pressure on social security systems in general and pension systems in particular. Largely because the number of people paying contributions to the pension system is shifting in an unfavorable way, at least in relative terms, to the people paying contributions. And extending the length of working life has been proposed as a potential remedy against that. The idea is quite easy. If we extend working life, then people will have less years of their life receiving pensions, and they will spend more years of their lives paying into the pension systems. And because of this, we have in many high-income countries seen policies aimed at extending the length of working life. For instance, currently in Germany, the statutory retirement age is being increased from 65 to 67, but almost all high-income countries have seen similar reforms. And given this context, one might ask whether we are really working longer. That's one of the questions I want to answer using working life expectancy. And related to that is that these policy reforms often have led to concerns, and also the scientific literature has quite a bit on that, that these reforms could potentially increase inequalities in the length of working life, as they often follow a one-size-fits-all approach. So, for instance, the reforms of statutory retirement ages, which we have seen in many countries, often apply in the same way to everyone, perhaps with a few exceptions. And there might be some groups for whom working longer is not a problem. If they need to spend an additional 1 or 2 or 3 years in the labor market, they will just do that and keep working. Or if they can't or don't want to work longer, they can live with the financial consequences. But there might be other groups for whom this might be very difficult, who can't work longer due to health reasons, or who might spend additional time in the labor market, not in employment, but in unemployment. And this leads to the second question here, how unequal really is the length of working life? And I have been working on this topic now for almost 10 years, and there's a series of papers which we did. And with respect to these two questions, do we really work longer and how unequal is the length of working life? We find that first, working life expectancy is not increasing everywhere, despite policy reforms aimed at extending the length of working life. That's notably the case for the 3 countries shown here, the US, Spain, and Italy. And we also find that inequalities in the length of working life are really substantial. And I will show you a couple of examples from my previous work to look a little into these points. So here we see trends in working life expectancy in Italy. This comes from a paper I have done together with Angelo Laurenti and Mikko Muskala. And in the figure, the x-axis shows the year, where we always look at yearly transitions, so transitions from 2003 to 2004, 2004 to 2005, and so on. The y-axis shows working life expectancy in years, where we look at working lives starting from age 15 up to age 99. So these higher ages, of course, don't contribute, but it would be possible in our model that people work. And then the different panels show different occupational groups, manual workers on the left, non-manual workers in the middle, and managers on the right. And then the lines show gender. So the gray solid line are women, and the black dashed line, that's men. And there's a couple of things going on, but what I want to talk about is the drop which we see in all lines. And I'm not sure, can you see my cursor? If not, I can perhaps also annotate a little bit. It should be something which you see, so you should now see some purple color. Let me know if not. In the left panel for manual workers, we see extreme drop in working life expectancy. For instance, for men, it was around, first let's change the color a little bit. Go here, slightly less than 35 years. And then it dropped by a bit more than 5 years to less than 29 years. And this was around the time of the financial crisis. And this drop, we don't only see that for men who are manual workers, we also see that for women and also for the other groups. So we always see these drops, perhaps a little bit less pronounced for male managers. So for the period which we studied in this paper, we see really an extreme drop in the length of working life. And at least for the years we looked at, it didn't go back to the initial values. It didn't recover. That might have changed. If you look at the last years we looked at, that was 2012, 2013. Now we are 12 years later, perhaps things have improved again. But at least at the time when we did this paper, the conclusion was that in Italy, working life expectancy dropped considerably. And we found similar things for Spain and the US. And I need to click here again. Right now it's still showing the annotation. How can I remove this? Oops. No, this is one too far. So I wanted to show you this as the next paper. Here we see trends in working life expectancy in Germany, where we focused on late working life, which was ages 55 and older. The results in this figure here are for ages 55 to 64. And the x-axis here in this plots now this plot is now the cohort, the year of birth, 1941 to 1955, and working life expectancy on the y-axis is still measured in years. The panels in the top show results for men, in the bottom for women. The panels on the left are for Western Germany, and the panels on the right for Eastern Germany, the former GDR. That's where I'm currently standing presenting. And the colors indicate educational attainment. So for instance, I'm looking at the panel in the top left for Western German men born in 1941, those with a high educational attainment, which for instance is university education. Working life expectancy was around 7 years during late working life, and that increased for the following birth cohorts. And for the last birth cohort, 1955, working life expectancy was around 8.5 years for highly educated Western German men. Now, this is an example where we see that all lines actually go up. So it's not the case that working life expectancy dropped everywhere, like I just showed you for Italy. For Germany, that's actually not the case, at least for these findings here. But what we see here is that inequality is pretty big between these groups. Let's perhaps focus on the bottom right panel. That's Eastern German women. And for the last cohort, the 1955 cohort, highly educated Eastern German women had a working life expectancy of around 8 years. And Eastern German women with low educational attainment born in the same year had a working life expectancy of only 4 years. They only worked half as much. So that's a pretty drastic difference. And at least in absolute terms, the inequality between these two groups, high and the low educated Eastern German women, increased over birth cohorts. If we look at the 1941 cohort, Eastern German women, the difference between the high and the low educated was only 3 years. And depending on which groups we compare in this plot here, there's a couple of differences which are even bigger than the ones I just talked about, and also a couple of other differences which increased. And we don't only find that for Germany, but this is a general finding. Last year, we published a review on socio-economic differences in working life expectancy that was led by Svetlana Solovieva and Taina Leinonen at the Finnish Institute of Occupational Health. And here is one of the figures from this paper. And it shows the left panel. Let's perhaps focus on that. That shows the highlights that again. That shows for each paper. So each paper is or each set of findings is a row. Some papers have several findings. It shows the difference between the highest and the lowest occupational group for men and women. So for instance, this paper here at the top, that is a paper which we did for Spain at age 15. The difference in working life expectancy for men, the difference between the highest and the lowest occupational group was around 11 years. and for women it was around 14 years. And then you see there's like all these points here are mainly at very high values, and these get slightly slower as lower, not slower, here at the bottom. But this is because we look here at higher ages, so age 40, age 50, age 60, when remaining working life expectancy is lower. And to account for that, we also have the relative differences here in the right panel. And those, in most cases, tend to be more than 20%. So there's pretty drastic differences by occupation, also by education, between genders, also regional differences. So those are really massive. So coming from the questions which I posed at the beginning, is the length of working life increasing? Well, it's not increasing everywhere. And what about inequalities in the length of working life? Those are substantial. So these are two things which we found out with our work. But what we don't know is why that is really the case. We do not know why is working life expectancy not increasing everywhere, and why these inequalities in working life expectancy are so substantial. And we don't know this because the previous work I have done and most of the literature on working life expectancy is largely descriptive, like the findings I just showed you. We show, oh, okay, working life expectancy is going up or down, and for this group, working life expectancy has this value, and for another group, it has that value. But we don't try to explain where that is coming from, or at least that is the current state of affairs. And I'm very interested in changing that. And today I will show you a paper which tries to look a little bit into why inequalities in working life expectancy are so substantial. And I will show you a paper I'm working on together with Alessandro Ferraldi from Sapienza University in Rome. And this is now the second part of the presentation and about smoking and socioeconomic inequalities in working life expectancy in the United States. Now, why do we look at smoking? How could smoking be linked to inequalities in working life expectancy? The argument has two parts. The first part is that there are large socioeconomic inequalities in the prevalence of smoking. You all know that. That has been demonstrated across the globe and also for the United States. The example we will look at here. The low educated tend to smoke more often, to have a higher prevalence of smoking compared to the high educated. And then the second part of the argument is that there's a link between smoking and working life expectancy. And there is several reasons to assume that there is a link. There isn't really any literature which shows that yet, except one paper, but which doesn't really focus on this question. And we can expect this link first due to the impact of smoking on health. If you are unhealthy because of smoking, it could be that you can't work anymore. A very perhaps a more specific example is COPD. That's a severe lung disease which can limit your ability to work, might disable you, and smoking greatly increases the risk of ever developing COPD. And the onset of COPD in smokers is usually in their late 50s, early 60s, so during late working life. And if you develop COPD in late working life, it could be so bad that it might cost you a couple of years of your working life. And there's many other diseases which might impact your ability to work, on which smoking has an impact. That's the first link. or the first reason why there might be a link. The second is that smoking also more directly impacts employment, not just through health. There is quite a bit of evidence that employers might discriminate against smokers in hiring decisions. For instance, because they expect that smokers are less productive because they take smoking breaks compared to non-smokers who might not take these breaks. And in some states in the US, it's actually legal to discriminate against smokers in hiring decisions. That's just like one example. There might be a couple of other reasons why smoking might hurt your employability. Another is simply that you might smell of smoke, might smell bad during a job interview, things like that. And then taking these two arguments together, the smoking prevalence and the link between smoking and working life expectancy, if the low educated have a higher smoking prevalence than the high educated, and smoking is bad for working life expectancy, it reduces working life expectancy, then we can expect that smoking reduces the working life expectancy of the low educated relative to the working life expectancy of the high educated. And we assess this empirically using data from the Health and Retirement Study, HRS. Probably most of you are familiar with the HRS. We use data for the years 92 to 2020. The HRS is a biannual longitudinal survey, which is representative of the US population aged 50 and older. So we look at older individuals, and for our analysis, that is 33,000, a little bit more individuals, who altogether contribute around 170,000 person years. Then our main outcome is not working life expectancy, but healthy working life expectancy. Healthy working life expectancy combines working life expectancy with being healthy. So healthy working life expectancy is the average lifetime spent in both employment and good health. We also look at unhealthy working life expectancy and healthy non-working life expectancy and unhealthy non-working life expectancy. But here in the presentation, I will show you results for healthy working life expectancy. Because of the data we use, we look at the remaining healthy working life expectancy at age 50. So again, we are focusing on older people, but given the topic we study, I think that makes a lot of sense, given that in particular the health impact of smoking does mainly happen, start to happen in people's 50s, late 50s, and not before. So if you're a smoker in your 30s, then smoking doesn't usually won't disable you. So we are looking at an age range where we expect to see an effect. We also define health in such a way that we can expect to see an effect. We define health through smoking-related chronic conditions, which includes heart diseases, lung diseases, stroke, and cancers. Generally in the HRS, there's around, what is it, like 10, a little bit less chronic conditions, which people are asked if they have those. And some of these conditions are clearly have a strong link with smoking, like heart and lung diseases, for instance. If you smoke, the risk of getting a lung disease, for instance, I mentioned that with COPD earlier, is greatly increased. Then there's a couple of diseases, of chronic conditions for which smoking is, there's evidence that it doesn't have an impact, or that it might even be slightly beneficial. That is the case for arthritis. Now, I don't think that smoking protects you from arthritis. There's like a parts of literature which suggests that, but that is probably suggest as selection. And then there's a couple of conditions which are a bit in between, where it's a bit unclear, where the link is, where there's an association perhaps, but which is moderate, and where the causal link is less clear. That is, for instance, the case with psychiatric conditions, with mental illness. And we focus on smoking-related conditions first to have an health conditions, because first we want to have an outcome which is specific to the treatment. If you would include conditions where we know that smoking doesn't have an impact, that would potentially could potentially lead to results which are biased to zero, because we include a couple of outcomes where we know that they're not affected by smoking. And more importantly, it allows us to run placebo tests on the non-smoking related chronic conditions. And I will come back to that later. For smoking status, we distinguish between people who never smoked, people who are former smokers, and people who are current smokers. For the data we are looking at, these people aged 50 plus, there is transitions between former and current smokers. So people who currently smoke and then stop smoking and then they become former smokers. There is a couple of former smokers who then start, who relapse and then start smoking again. But there's almost no transitions from people who never smoked to people who smoke. In your late 50s, you don't start smoking. There's like 3, 4, 5, I don't remember, people in the data where that seems to be the case, but we guess it's probably measurement error and we drop those, but those are not relevant in any way for the results of the analysis. Now, how do we model this data? We use a multi-state approach. Multi-state models are extensions of survival analysis, simple survival analysis, and competing risk models. I guess most of you might be familiar with multi-state models, but for those of you who are not, in simple survival analysis, you look at the transition from one state to one other state. So for instance, from employment to retirement. In competing risks, which then is a generalization of the simple survival analysis models, you look at the transition from one state to several other states. For instance, from employment to retirement, unemployment, or inactivity, or death. And that takes into account that this transition in simple survival analysis from employment to retirement might not happen to everyone, and different things might happen to some other people. That is taken into account with these transitions to these other states. And multi-state models then take this a step further and allow arbitrary transitions between all states back and forth. So you can transition from employed to unemployed, and then from unemployed to employment, from employment perhaps to inactive, and then to retired. And in our application, the model has 5 states, which are shown with these boxes here. You can be healthy working, you can be unhealthy and working, you can be healthy non-working, you can be unhealthy non-working, and you can be dead. And the arrows indicate the possible transitions. So there's no arrows pointing away from dead. So once you're dead, you stay dead. And in the HRS data, there might be a trajectory like this. There might be someone who at age 50 is healthy and working. And then perhaps at age 60, that person transitions from healthy working to unhealthy working, perhaps because they were a smoker. They were a smoker and then got sick, perhaps COPD, and they became unhealthy, and then they worked for another 2 years despite being unhealthy. And at age 62, they then transition from unhealthy working to unhealthy non-working. And then perhaps at age 69, they die. We have trajectories like this in the data. and our model then just allows for all possible trajectories. A side note here, if you're interested in using discrete time multi-state models, which work excellently well for panel data, there is now an R package which yours truly developed, which I think now is relatively far developed, implements lots and lots and lots of features, should be hopefully mostly bug-free, and it is available on GitHub and comes with a lot of documentation, and on GitHub you will also find a tutorial how to use that package. And I used that package with the HRS data to produce the findings which I am going to show you here. Well, let's perhaps move to this first here. Here we see the results on smoking prevalence in the data. This is not based on a multi-state model. This is the first part of the argument. So I said link between smoking and working life expectancy has two parts. The first part of the argument is smoking prevalence. And here we see smoking prevalence by education, where I'm just comparing the high to the low educated. There's also a middle category, medium education, but I'm not going to show that here to keep things simple. Highly educated are people with university or college education. Low educated is less than high school degree. Now remember, these are people who are in their 50s or older, so also 60s, 70s, 80s, and so on. And some of those in the 1990s. So there is some very old cohorts for which it was not super uncommon to have less than a high school degree, actually. And what we see here is also that smoking was like relatively common in these old cohorts. So for instance, for the low educated, smoking prevalence at age 50, 37% never smoked, which means that close to 2/3, a little bit less, of the low educated actually did smoke at some point. And compare that to the high educated, where only 47% current or former smokers, meaning that like half of them never smoked. So here we see this big difference in smoking prevalence between these two groups. Again, this is nothing new. Where we now have something new, the link between smoking and working life expectancy. This figure shows a healthy working life expectancy at age 50 measured in years on the x-axis, and educational attainment on the y-axis. So the top row is high educated, bottom row is low educated, and the colors indicate smoking status. So for instance, this black dot in the top row, those are highly educated individuals who never smoked. And at age 50, these people could expect a little bit more than 11 years being employed and in good health. Compare that to current smokers. Those people at age 50 could expect a little bit less than 7 years of healthy working life expectancy. So a difference compared to the never smokers of a bit more than 4 years. Former smokers, the green dot is in between these two groups. And for the low educated, everything is shifted a bit to the left. So the differences between the smoking status groups are roughly the same as for the high educated. The impact of smoking is the same, just coming from different baseline levels. So compared to the highly educated counterparts, the low educated on average work less. And now we can combine all of what I just showed you. And calculate healthy working life expectancy at age 50 for the high and the low educated, averaging over the smoking status groups. So not conditioning on smoking status. So for the high educated, healthy working life expectancy at age 50 was 10 point something years, whereas for the low educated, it was 6 point something years. This is what we observe in the data. What we can also do is we can calculate a counterfactual healthy working life expectancy, assuming that there wouldn't be an inequality in the prevalence of smoking. And we do that by taking the smoking prevalence of the highly educated and applying that to the low educated. So we calculate a healthy working life expectancy for the low educated, assuming they would have the same smoking prevalence as the highly educated, which means that they would smoke less. And then we get this counterfactual value here. You can think of this as an imaginary intervention in which we perhaps somehow reached out to the low educated, told them, no, smoking is bad for you. And because of that, less of them picked up smoking, only as much as the high educated. And now for the low educated, we have observed healthy working life expectancy of 6 point something years. The counterfactual blue value, which is a little bit less than 8 years. And now we can compare both values to the high educated. The difference between the observed values is a solid black line. And the difference between the counterfactual value for the low educated and the observed value for the high educated. So the scenario in which we remove the inequality in the prevalence of smoking, this is now added solid blue line, and that is a reduction of the inequality by roughly 1/3. And based on this, we can say that smoking causes roughly 1/3 of the inequality in healthy working life expectancy between the high and the low educated. Now, coming to the discussion, slash still some results in a sense. What I just said is a causal interpretation. I'm not talking about associations. I'm doing this because this is supported by the placebo tests we ran. In these placebo tests, we regress use smoking status as a predictor for health and use non-smoking related diseases as an outcome. So like arthritis, for instance. In these models, smoking shouldn't have an impact on health because we look at non-smoking related diseases. And if we find an impact, that means there's some selection or confounding going on. And we have what we find in these placebo tests is that for the former smoker group, there might be some selections, probably some reverse causality happening. That likely is the case because the former smokers group is a group which includes people for which not health is affected by the smoking status, but the reverse. So the health status affects the smoking status. What that means is some people might become sick, unhealthy, and then they just stop smoking. But overall, the magnitude which we find is not enough to completely reverse our interpretations. There's a couple of caveats to our findings. We use a period perspective, not a cohort perspective. That is something which I didn't fully explain in my presentation, but I think some of the findings in the first part already kind of like hinted at this period cohort perspective thing, that both things are possible. With the HRS, cohort perspective is a bit difficult. That's why we use the period perspective. The results I showed you assume that the smoking status is constant. So the results imply that the never smoker group, that those people really never pick up smoking. The former smoker group is set up in such a way that it means that people at age 50 are former smokers and they never relapse. And current smokers are people who are current smokers at age 50 and they never stop. These are all groups which exist in the population, but it would perhaps be possible to look at mixed trajectories, so people who perhaps are current smokers from age 50 to age 60, and then they become former smokers. That would be possible, but we haven't done that yet. I also already mentioned that some of the cohorts we look at were born in the 1920s, 1930s, 1940s, for which smoking behavior was like really different. These people grew up in a world where you could just smoke everywhere. And for younger cohorts, that is very different. What our findings mean for future cohorts, so to speak, younger cohorts, is not super clear. One can speculate a little bit perhaps about that. Regarding the causal interpretation, in a sense, what we are doing is an incomplete causal decomposition. There are more components to true causal decompositions, but there's a couple of reasons why I think that what we have done here is actually enough. So coming back to the question of the second part, why inequalities in working life expectancy are substantial. Well, we can now say, okay, so it's at least partly due to smoking and health behaviors. Thank you very much for your attention. And I hope I'm not, no, I guess I'm